Good morning, everyone. Welcome back. I am Anna Deloy, one of the other interventional endoscopists at the University of Colorado. Our next session will cover biliary topics. You can find supporting material for this session below the session description. Our first biliary presentation is by Dr. Chahal, Director of the Advanced Endoscopy Fellowship at the Cleveland Clinic. Dr. Chahal is an expert in advanced endoscopy and interventional EUS. She will be discussing the management of biliary and anastomotic strictures. Please play this video.
Hello, everyone. My name is Chahal. I would like to thank Dr. Sachin Wani and Dr. Raj Jha for giving me this opportunity. We're going to talk about management of biliary and anastomotic strictures. So these are my disclosures. And the learning objectives of this talk are really simply put twofold. One, we discuss the endoscopic management of anastomotic biliary strictures in conventional anatomy, and then discuss the management in patients who have surgically altered anatomy. So as most of us know, the three most common scenarios that we encounter in our endo suites with patient coming in with an anastomotic stricture is, first is post-liver transplant patient population, either with duct-to-duct anastomosis or those who have Roux-en-Y anastomosis. Second most common scenario is those who have bilioenteric anastomosis, and common post-operative patients being those who had Whipple operation or pancreaticoduodenectomy. And finally, those who are coming in with the bile duct injury, most commonly sustained during cholecystectomy. And as a result of the injury, either they still have conventional anatomy and they have a stricture in the common bile duct, or to manage the complications from the iatrogenic injury, they underwent hepaticojejunostomy and they have a stricture related to that. For all intention and purposes, the anastomotic stricture of hepaticojejunostomy, regardless of the surgically altered anatomy, whether that was Whipple or bile duct, if the roux limb is not too long like bariatric patients, the management would be largely similar. And we are going to talk about that over the course of this talk. So starting with post-liver transplant anastomotic biliary stricture, they're more common in those who undergo living donor liver transplant. Up to 1/3 of them can have strictures compared to deceased donor liver transplant. And there are several risk factors that have been identified that can lead to anastomotic stricture. And they range from the preoperative phase of these patients, those who have advanced age, either donor or recipient, being the female donor, patients who undergo living donor transplant, patients who have small bile duct diameter at the time of transplant, patients who have multiple anastomosis, and we'll discuss a case showcasing this, and patients who have PSC. Again, several intraoperative risk factors that can lead to anastomotic stricture, and several postoperative, including those who get complications like bile leak or hepatic artery thrombosis or stenosis. There are several factors that also affect clinical success of endoscopy. And the more patients who have deceased donor liver transplant, they tend to have better outcome in terms of an endoscopic stricture resolution compared to those who have living donor liver transplant. Patients who present and are treated earlier in the course of post-transplant period, especially within first 6 months, they tend to have higher clinical success rate for stricture resolution than those who present more than 6 months after their transplant. Patients who undergo longer duration of stenting, especially longer than 3 months, and studies show that if you have indwell stent time for up to 12 months, the stricture resolution is in high 90s, 96 to 98%, with a low recurrence rate followed over a long time. And finally, patients who undergo multiple plastic stenting as a strategy for stricture resolution compared to fully covered metal stents, the efficacy is the same. So some of the technical aspects, all these patients, especially with the conventional anatomy, we start with ERCP. And these patients all should be given prophylactic antibiotics in their post-liver transplant state. And there are three basically stages for stricture management. One, we get the guide wire across the stricture. Two, we dilate the stricture. And three, we put a stent across this. However, keep in mind, if somebody is in a very early post-transplant phase, especially first month, first 4 weeks, we should not be dilating the anastomosis, as it can lead to rupture of the anastomosis. When choosing the balloon size, the size of the balloon should be matched to the size of the duct above and below the stricture. And finally, even if we see that with balloon dilation, the waist of the balloon has effaced, these patients still should be stented because the stricture recurrence is significantly high if you just leave these patients with balloon dilation alone. So when it comes to stenting, there can be 4 different strategies. These patients, they can get multiple plastic stent right from the get-go, leave the stent in place, you pack in as many as you can, and then you wait if the patient gets abnormal liver test or they get cholangitic. Obviously not a favored approach for them, to wait before they get symptomatic, or you can bring them back based on the number and size of the stents you pack in every 3 months or 4 months. Second strategy is more rapid upgrading of the stents. You bring them back every 2 weeks, you change the stents out and put in a larger stent or more number of stents till the stricture is resolved. Third strategy for multiple plastic stenting is you put some stents in, bring them back, you leave the old stents in place and put a new one in tandem alongside the old stents and continue till the stricture resolves. And finally, you can leave a fully covered self-expandable metal stent in. Again, we'll discuss some of the RCTs that have been out there. Efficacy is similar, but fully covered stents have been shown to have longer stent patency and are most cost-effective, as shown in a study that came from our center, our group, published in Digestive Disease and Sciences. So here I've encapsulated 4 randomized controlled trials that compare multiple plastic stenting versus fully covered metal stent for treatment of post-liver transplant anastomotic stricture. As you see, the stricture resolution is quite comparable. However, not surprisingly, the number of ERCPs needed for multiple plastic stenting was significantly higher than fully covered self-expandable metal stent. Also keep in mind high stent migration rate with the fully covered SEMS, as high as 33%. And as mentioned earlier, the longer you leave the stents in, higher is the stricture resolution rate. So usually when we encounter these anastomotic strictures in an endo suite, majority of the patients we are able to manage with conventional tools and techniques. Not uncommonly, we'll see somebody come in with really high-grade angulated anastomotic stricture. And in those cases, these are the 3 tools that have helped me out. First is the use of a fully hydrophilic angle tip glide wire. Second is the use of extremely small caliber 2 millimeter cardiac angioplasty balloons. So a couple things about the use of cardiac angioplasty balloons. They're small caliber, as I mentioned, 2 millimeter. They take 0.18 wire, so they cannot accommodate any wire larger than that. And they are often 150 to 155 centimeter long, which means that if you're dealing with living donor liver transplant with a high up anastomosis, these balloons will not be long enough to reach that area. But for traditional duct-to-duct anastomosis, these have come in handy a couple of times. And then finally, use of per-oral cholangioscopy that can help visualize the stricture and under direct cholangioscopy guidance, help pass the guide wire across. Again, there is an extreme paucity of data on the use of these tools in patients with anastomotic stricture. Couple small case series published on use of cholangioscopy. The one published by Martin in Endoscopy in 2017 showed 5 patients where they failed traditional methods and cholangioscopy was successful in traversing the stricture, 100% of those patients. And another small study by Wu of 9 patients showed about 60% success with where traditional tools and techniques have failed. So this is a case which basically highlights all these tools and techniques that I mentioned. And this also highlights how important it is to know the surgical anatomy of the patient. Read the operative note, talk to the surgeons if you are not sure, look at the imaging before we embark on an endoscopy. So in this fluoroscopic image, you can see a nice filling of the left hepatic duct system. Middle image, you can see the donor cystic duct, and then you can see the recipient cystic duct. And this was a unique case where the donor right hepatic duct was anastomosed to the recipient cystic duct. And that's where the high-grade stricture was. So we tried all the traditional tools and techniques. We got in with the all wires, including 035, 025, 21, and 018. They could not traverse this high-grade anastomosis between cystic duct and donor right hepatic duct. And then finally, we went on to do cholangioscopy, and you can see this really difficult angulation in order to get into the recipient duct, and we were able to pass an 018 wire across. It did not accommodate any bigger wire. And then we tried to pass a 4mm balloon, which failed. So we resorted to cardiac angioplasty 2mm balloon, and you can see how high grade the stricture was, and subsequently went on to dilate with the after 2 4mm stent, and patient remains asymptomatic with 2-year follow-up. So try to have these tools in your toolbox for some of these sticky situations. So moving on from conventional duct to Roux-en-Y, biliary anastomosis, and post-liver transplant. So this kind of anastomosis is usually created in patients who have underlying PSC and they undergo liver transplant. The Roux limb is usually short, about 40 centimeters. And as a result, we are able to navigate this with the pediatric colonoscope or adult colonoscope. Again, very limited data on the success rate of endoscopy in managing anastomotic biliary strictures. We published data in liver transplantation with 32 patients. Out of those 32 patients, 10 were referred to us for anastomotic stricture, and endoscopy was successful in 9 out of 10 patients in stricture reaching the anastomosis, dilating the stricture, and stent placement. So when you are performing endoscopy in these patients, some of the techniques that can help you achieve success is usually we start patient with left lateral. If you have difficulty navigating acute turns in the Roux limb, change the position to supine, use extracorporeal abdominal pressure, use of air cholangiogram. Especially, if you see a nice air cholangiogram, it's unlikely that patient has an extremely high-grade biliary anastomotic stricture. Be mindful of the size and the length of accessories that you are using, especially with the colonoscope. And then finally, don't forget to tattoo the Roux limb, because these are the patients who often require multiple endoscopies. So it'll be easy for the next time around if you see the Roux limb being tattooed. What about single balloon endoscopy in the Roux-en-Y anastomosis and liver transplant? So again, not a significant amount of data. This is the study which looked at single balloon versus variable stiffness colonoscope. And even though they did not find any statistical difference in the success rate for the first encounter, the study authors noted that the success rate of single balloon increased over the 4-year of the study period. And those patients who failed with adult or pediatric colonoscope, the endoscopists were able to achieve clinical and technical success with the use of single balloon endoscopy conversion. So take home point, you can start if you don't have a single balloon endoscope, start with the variable stiffness colonoscope. If you're using adult colonoscope, you have an advantage of a bigger channel passing through things like fully covered metal stent. But if you have a pediatric colonoscope, you're limited to 7 French accessories, and single balloon enteroscope, same thing. But if you have a single balloon enteroscope, possibly start with that as a first endoscope in those patients. So moving on from liver transplant to bilioenteric anastomosis, specifically patients who have Whipple surgery or pancreatic duodenectomy. Again, limited data, how good is single balloon versus double balloon in managing anastomotic stricture in this patient population? A small series of 38 procedures performed in 4 patients did not find any difference in technical and clinical success for managing anastomotic strictures using SBE versus DBE. And for the Whipple operation, we published our data in endoscopy, and we found in 51 patients, we were able to achieve technical and clinical success in 84% of those patients by using either side viewer or variable stiffness colonoscope. Now, keep in mind, since this study has been published, the rule limbs have become longer, and also, especially if it's an anti-colic, it'll be very difficult to use a side viewer scope. So more recently, we've been using either single balloon enteroscope or a variable stiffness colonoscope in patients with post-Whipple anatomy. So this is a table that summarizes really tool needed for Whipple anatomy, actually for any altered anatomy for that matter. So if you're starting with a duodenoscope, you can use all your standard ERCP accessories, but for pediatric and adult colonoscope, we talked about the channel size. For single balloon and double balloon, you really have to have long wire accessories. There are special longer length balloons and longer length sphincterotomes. Patient position is quite variable, starting with left lateral, so you have to navigate the fluoroscopy for that. And most of these patients are under general anesthesia, and obviously you're using CO2 insufflation instead of air for these procedures. So some of the tricks that you can use to facilitate bilioenteric anastomosis access in Whipple anatomy is, again, changing the endoscope, changing position of the patient, using abdominal pressure, use interpreting cholangiogram, know your tools and the length of the tools, and secretin provocation. It would be really nice if you have a patient with this big biliary enteric anastomosis, but most of the times it's pinpoint. And oftentimes, you can, if you're not able to reach the anastomosis, try to put patient in Trendelenburg and flirt the afferent limb with a contrast to see if the contrast goes into the bile duct to get a diagnostic cholangiogram. Just something that you can try in this patient population. So this is another case which basically shows how endoscopy can be helpful. This is a patient who underwent Whipple operation for pancreatic head cancer, was complicated by bile leak. Patient underwent surgical redo for management of bile leak, still had persistent bile leak, ended up with the percutaneous drain, internal, external on the right system, but they were not able to internalize the left system. And the radiologist also noted that there was total lack of contrast passage from the left system into the bowel, into the afferent limb. And again, CT demonstrating that how this was just an external drain because of failure of contrast to go into the afferent limb. So at this point, the patient was referred to me to see if we can salvage the situation with the help of endoscopy. So when we went down into the afferent limb, we were able to reach the bilioenteric anastomosis. And here you can see nice wide open biliary anastomosis. And if you were not aware of the surgical history of the patient, you would assume that this is, the right system, this is the left system. But in fact, this patient had 2 different anastomoses. So the right duct was sewed to the bile duct separately from the left duct. So keep in mind, sometimes you can encounter these 2 separate anastomoses in post-transplant population, where you have to find both anastomoses if there's a problem with both. So this is external, internal PTC drain coming in from the right, and then we injected contrast from the left, and you can see complete cutoff. There's a total disconnection of the left system. So this is where we found out that this was inadvertently closed off. And we advanced a small 018 guide wire through the percutaneous tract. And here you can see the extrinsic impression with the one-on-one. And it's like a percutaneous gastrostomy tube placement. So under fluoroscopic and endoscopic guidance, where the indentation was, I made a fistulotomy and created a fistula, was able to advance the wire from percutaneous tract. We grasped the wire and brought it out through the endoscope channel, and then over the wire, we placed a fully covered metal stent. So basically, we recanalized the disconnected left hepatic duct, and now you can see the continuity is restored with the nice cholangiogram. Patient did well with the procedure. So if these standard tools and technique using standard endoscopes, they fail, we can move on to EUS guided intervention. So how useful is EUS in managing anastomotic biliary stricture? Again, very limited data, and most of the data obviously is patient with surgically altered anatomy, variable success rate and variable complications, but on an average around about 20%, and they range from pain, from bile, bile peritonitis, cholangitis, pancreatitis, subcapsular hematoma. And then there is a lack of standardization in the tools and the techniques that we do for these EUS guided interventions. So this table summarizes the limited data that is out there for the role of EUS in management of anastomotic stricture. This also highlights, small case series, multiple different tools used for tract dilation, different type of stents that were used for hepaticoenterostomy creation. The timing was also either it was one stage, which means that they created hepaticoenterostomy and placed and then went in and did the antegrade balloon dilation of the anastomotic stricture and antegrade stenting, versus two stage where they created hepaticoenterostomy, placed a fully covered self-expandable metal stent, brought the patient back a few weeks later, and then they did antegrade balloon dilation of the stricture and stent placement. Technical success quite variable, and adverse event also variable from as low as 8% to 70%. The failure was largely attributed to failure to pass wire across the anastomotic stricture or failure to puncture the bile duct, because unlike malignant obstruction, benign anastomotic strictures, they don't have a really large intrahepatic biliary dilation, so that can make EUS guided interventions more tricky. So obviously these need more experience. They can be time consuming, and they can take up a chunk of your schedule. The success and complication rate are quite variable based on what type of EUS guided intervention you are doing. Is that rendezvous, antegrade access, hepaticogastrostomy with peroral cholangioscopy intervention, or you're trying to access the afferent limb via LAMS? And some of the technical consideration based on all these different techniques, especially, for example, EUS guided rendezvous, first and foremost, you need to make sure that you are able to reach the bilioenteric anastomosis with your either enteroscope or with your colonoscope. The last thing you want to do is do a rendezvous and then find out you're not able to reach the anastomosis. Then you have to convert either everything antegrade or you're creating hepaticoenterostomy. You obviously need the right tools like long wires. Start with a 19-gauge wire. Be careful of the wire sharing, and you are usually going with the left hepatic lobe segment 2 or 3. Be careful, look at the endoscope position fluoroscopically, endoscopically, so you're not going through the mediastinum. And again, this is a case where we did the rendezvous through a really tiny anastomosis. We're able to get the wire across, and then over the wire, we are able to place a fully covered metal stent in this particular patient. So what about other EUS intervention like antegrade stenting or hepaticogastrostomy? For antegrade stenting, important thing is you keep in mind the bile leak at the access site. So for that reason, you don't want to dilate the access site any more than 6 millimeter, keep it between 4 to 6 millimeter. And then try to maintain the stable scope position. You're checking endoscopically and fluoroscopically, staying close to the stomach. So for EOS-guided hepatogastrostomy, we usually use long, fully covered metal stents, and you are leaving about 3 centimeters out into the stomach. And when we are doing stent deployment, be mindful of the breathing, the liver moving, and then you usually leave about a double pigtail stent through it to prevent the migration in this scenario. So finally, a slide on the bile duct injury. As I mentioned, the most common scenario is post-cholecystectomy, where they can either have a conventional anatomy or they can end up with hepatogenostomy. Most of these, again, can be managed with multiple plastic stenting or fully covered metal stent. However, bile duct injuries strictures tend to be much more fibrotic, and generally they do better with longer stent indwell time, longer than 6 months, preferably 8 to 12 months. In cases where there has been a complete disconnection of the bile duct, innovative techniques like magnetic compression and anastomosis have been shown to be helpful in limited data. For example, study published in GI endoscopy in 2016 on 37 patients showed 90% success rate in achieving recanalization and only 2 recurrences at 41-month follow-up. The data on intraductal bipolar RFA and biodegradable stent is limiting, but these are the 2 other technologies that we need to keep in mind. We don't have biodegradable stent available in the United States, something we are looking forward to. So in conclusion, endoscopy carries a high technical and clinical success rate in the management of anastomotic stricture in patients post-liver transplant and bilioenteric anastomosis. Choice of tools and technique depend on anatomy and operator experience, and novel techniques like magnetic compression, intraductal RFA, and biodegradable stent, they need more research. Thank you so much for your time.